these are my disclosures. So the diagnostic process, in the diagnostic process of amyloidosis, several steps can be distinguished. The diagnosis of amyloidosis, of course, first starts with a suspicion of amyloidosis based on the recognition of signs and symptoms. And if there is a suspicion, the presence of amyloid should be confirmed. So it should be the presence of amyloid should be confirmed, and the amyloid should be typed. Next, the organ involvement should be mapped, and disease severity should be assessed. And of course, the underlying disease process and the precursor protein should be assessed. And then after the start of treatment, the treatment response should be monitored, and we should monitor for disease progression or disease relapse. But there are, of course, challenges. Unfortunately, there still is a considerable diagnostic delay. There should be improvement in the recognition of signs and symptoms of AL amyloidosis. So we should invest in an early diagnosis of amyloid. It's important that we have assays, methods for correct typing of amyloid. We should have precision tools for assessing organ involvement and disease severity. And the current assays for measuring the precursor protein measure the total level of free light chains, but do not specifically measure the amyloidogenic and toxic free light chain, and that should be very much desired. That's desired. So and eventually we need sensitive tools for establishing residual disease and also reliable criteria for disease progression. So let's first discuss the latest developments in improving the early recognition and early detection of amyloid. Of course, there are many initiatives to increase awareness, and this meeting is a great example of that. And you can also see, if you look at PubMed, which is an online search engine for scientific publications, that the interest in AL amyloidosis is increasing. The number of publications is exponentially increasing during the last decade. So that's good, and that suggests that the interest in this disease is in the medical community is increasing. But does that automatically mean that we also are getting better in recognizing early symptoms, signs, red flags? I don't know. During the ISA symposium, there were several studies were presented that show the use of artificial intelligence for the early recognition and detection of amyloid. Artificial intelligence is the ability of a machine to perform tasks that typically require human intelligence. So things like decision-making, learning, reasoning. And this figure shows how artificial intelligence can be used to do characterization. By using a machine learning as a simple machine learning approach. So first you have to enter a image into the computer, and the observer has to select the features that are important for making distinction or for recognition, and then the computer, by using these features, can characterize and analyze new images to decide what to characterize. And this simple model, this technique is applied to electrocardiograms to recognize cardiac amyloidosis, also to echocardiography to recognize cardiac amyloidosis, to CMR, and also to myocardial biopsies and other biopsies to detect amyloid. And Krogan and co-workers presented a review of 13 articles that show that artificial intelligence is indeed helpful in early recognition and detection. So I think this is a promising development. So then another aspect is that we should have assays for correct typing. Amyloidosis is not one disease, it's a group of diseases. Depending on which precursor protein builds up, you can distinguish different types of amyloid, and correct typing of the amyloid is fundamental for managing the disease effectively. And immunohistochemical typing is widely available and is therefore also most commonly used for typing. But this figure illustrates that immunohistochemical typing is not always conclusive. It may be difficult so now and then. This figure shows sections of a bone marrow biopsy in which there is amyloid deposition, and it has been stained for the kappa-free light chain, the lambda-free light chain, and also serum amyloid A and transthyretin. And as you can see, there is brown staining, which suggests that these precursor proteins are present in the tissue, but it stains for the kappa-free light chain, as well for transthyretin, and also a bit for the lambda-free light chain. So it shows that immunohistochemistry is not always conclusive. Luckily, fortunately, we have more sophisticated techniques to type amyloid. Immunoelectron microscopy is such a technique, and also mass spectrometry is such a technique, but these techniques are not widely available and only available at some centers in the world. But during the last ISA meeting, some studies were presented showing that mass spectrometry is a very sensitive and specific method for typing, and the mass spectrometry has a high diagnostic yield for typing amyloid and can be used. But there was also a presentation of an ISA survey that showed that access to accurate typing is a global problem, and that also means that we should increase networking and collaboration for better access to accurate typing. So based on the assays that we have, and given that immunohistochemistry is widely available and performs well in many cases, immunohistochemistry still is first choice for typing of amyloid, but if it is inconclusive, the advice is to search for a center that can do typing using immunoelectron microscopy or mass spectrometry to correct type the amyloid. For the assessment of organ involvement and disease severity, we need precision tools. We now rely on consensus criteria, and especially cardiac involvement is a key determinant in the prognosis of AL amyloidosis. We now often use echocardiography and MRI for mapping cardiac involvement, but these techniques have some limitations. They have limited sensitivity and specificity for diagnosing cardiac amyloidosis. They do not distinguish, or at least they do not distinguish between AL and ATTR or other types of cardiac amyloidosis, and they are not useful for exact quantification of the amyloids. So there are new nuclear imaging techniques, especially a tracer called efusamitide, and also fluor-beta-per and fluor-beta-ben that keep promise for being able to better assess cardiac involvement in AL amyloidosis. During the ISA symposium, several studies were presented showing that efusamitide, a tracer and a peptide that binds to amyloid fibrils alongside the longitudinal axis of the fibrils, holds promise for diagnosing cardiac amyloidosis as a SPECT tracer, but also as a PET tracer, which also allows quantification of the amyloid. And there were also studies showing that also other organ involvement may be mapped with this tracer. So I think this is a very promising tracer to map organ involvement in AL amyloidosis. There were also other studies showing other traces, fluor beta pair and fluor beta ben, which are traces that were originally used for visualizing amyloid beta amyloids, which is deposited in Alzheimer's disease. But these traces also bind to other types of amyloidosis. And these studies presented during ISA showed that these tracers may also be useful for identifying cardiac AL amyloidosis, although it should still be optimized and further investigated. So a phase 3 study is underway with fluor beta ben PET-CT scanning to see the real value of this tracer in AL amyloidosis. So another challenge is measuring the amyloidogenic free light chain. So as I already explained, the current assays do not specifically measure the abnormal free light chains, the amyloidogenic or toxic free light chains, but they just measure the whole pool of free light chains. And the ideal assay would measure only the amyloidogenic free light chain. Yesterday we heard about a amyloid assay, and this was also presented during the ISA symposium, which is a new blood-based diagnostic test for lambda AL amyloidosis that specifically quantifies the unstable lambda free light chain. So the amyloidogenic free light chain is, because it's amyloidogenic, because it's abnormal, it's also more prone to cleavage by proteases. And this technique makes use of that. So the total pool of free light chains in the blood is cleaved by proteases, and only the unstable free light chains will be cleaved, and that's probably the amyloidogenic free light chain, and the levels of this cleaved constant region of the free light chain can be measured with an immunoassay. And this assay is very promising. It has potential clinical utility in screening patients with monoclonal gammopathies. It can be used for the early diagnosis of AL lambda amyloidosis, but also for monitoring treatment response, disease recurrence, and it also may have prognostic value. That was also shown during the ISA symposium. And there are also other techniques to measure monoclonal proteins. There were presentations about mass spectrometry-based techniques to measure the intact monoclonal proteins. And this study showed that it's a very sensitive method, more sensitive than the currently used immunofixation for the quantification of the total monoclonal protein. But there are also mass spectrometry-based assays to measure levels of, or at least to detect the free light chains, and those are very sensitive. And this study presented during ISA showed that that even in patients that have complete hematological remission based on the conventional criteria, sometimes have still residual disease visible using this technique, and those patients have a worse outcome as compared to the patients that do not have residual disease using this technique. So I think it's a very promising way of looking to minimal residual disease. And then, of course, we also need criteria, and Palladini proposed new criteria for hematological progression. He proposed an increase of more than 10% in the difference between the involved free light chain and uninvolved free light chain, or an increase of more than 50 milligrams per liter from the best hematologic response. And he showed that when combined, these criteria, both cutoffs were able to predict organ progression with a specificity of 96%. So that's really promising, and validation of this study is ongoing in the Heidelberg cohort. So I think that's also very interesting what that will bring. So in conclusion, I think implementation of artificial intelligence will be helpful in early recognition, detection of amyloids. I think it's important that we collaborate and organize networks for reliable typing of amyloids. there are new imaging tracers on their way that are very promising for the detection of cardiac involvement, but maybe also for other organ involvement in AL amyloidosis. The amyloid assessment is, I think, one of the first assays, or maybe the first assay, that's able to identify the amyloidogenic free light chain and quantify levels of this free light chain, although it's limited to the lambda free light chain. And I also think that the mass spectrometry-based assays for serological residual, for the determination of serological residual disease are very promising, and criteria for hematological progression are on their way. So thank you very much.
Thank you, Hans, for this nice presentation showing the differential steps that we have from the start of the presentation, even before the presentation of the patient, until the treatment and how to monitor treatment. And are there questions in the audience?
Maybe I start with the first question. You mentioned that globally there are many problems to have access for centers to type accurately. But you have not kind of told us how in your center you are doing the typing actually. You might elaborate a little bit on that.
Yeah, we also primarily use immunohistochemistry, but we also use immunochemistry on subcutaneous abdominal fat tissue, which is an ELISA-based approach. And with the antibodies we use, we experience that in many cases we can reliably type the amyloids, but there are still some cases where we cannot reliably type, and then we collaborate with the NAC in London and send the material to London for mass spectrometry. So we already have established the collaboration for typing, and that works fine for us.
If you need all the three approaches, how much time do you need for the first biopsy and then you get an accurate result? Because time, which you heard right now, is crucial in some patients.
Yeah, so immunohistochemistry takes about a week, and parallel to the immunohistochemistry, we also do immunochemical typing of the amyloids, and we have that within 3 weeks, but often the immunohistochemistry is a bit earlier. And then, of course, there may come some delay if we have to send the material to London. So that is indeed a problem. It causes delay. I agree. Yeah. But we also use, of course, histological or typing of the amyloid is very important. But we, of course, also look at the context of the patient, and that sometimes also help. And if we are very confident that the patient has AL amyloidosis, we sometimes start treatment awaiting the results of spectrometry.
Thanks a lot for your presentation. I have a question about the evaluation of the answer to the treatment. Do you think that in the future the liquid biopsy, the mass spec in the blood, could replace the MRD evaluation on the bone marrow?
Yes, I think so. I think so. There has been at least one study, I think, by the Mayo clinics that showed that mass spectrometry-based assessment of residual disease on blood performs even better than next-generation flow cytometry to assess minimal residual disease. So I can imagine that in the future we do not even need bone marrow examination to establish residual disease.
Just a comment for amyloid typing, we mostly rely on immunofluorescence on frozen tissue, which is a very sensitive technique. It's much more sensitive and reliable in our hands than immunohistochemistry. And the advantage is that you get the results in a few hours, not in a week. So I think that many centers should try to develop immunofluorescence studies rather than immunohistochemistry. It's much much easier to interpret the results than with immunohistochemistry most of the time.
Well, thank you for this remark. That's indeed a very interesting technique. And of course, there are many other things that I did not discuss, and maybe there are other diagnostic developments that should be discussed. But please fill me in then.
In the past, I heard a lot of things about SAP scintigraphy. Well, some people did that. And, well, there is a new scintigraphic techniques you mentioned. Do you think it has more value in the clinic, or what do you think if you compare these techniques with each other? And what will be the future?
Yeah, so the SIP scintigraphy is only available in London and in Groningen, at our center. So that's the first limitation of SIP scintigraphy, whereas these tracers are probably widely available, or will become widely available. And another thing is that SIP scintigraphy is useful for mapping involvement of the kidneys, liver and spleen, but it is not useful for looking for cardiac involvement or other organ involvement. We sometimes see other organ involvement, but it's not validated for that purpose. So it has limitations, and I think these tracers may become widely available and show promise to be able to reliable map cardiac involvement and also other organ involvement.
Maybe we can dig into a little bit more in that, in those imaging. As Bouke already told, that there's a long history about imaging, and we in Germany actually we don't have we don't have SAP, and also we don't have real access to all of these. My question is really, if this is going to work, is there really a chance that we measure organ response with those imaging techniques? Because that's for me the most crucial question, because relying on all those biomarkers has some advantages but also disadvantages. So I think here there is really a gap which we should fill. But what would you say? Is there a chance with those new techniques to measure organ response?
Yes, absolutely. So the biomarkers have some limitations. For example, if you want to look for cardiac progression in a patient with renal insufficiency, then NT-proBNP is difficult to interpret, for example. So there are situations, or also in a patient with, well, there are several examples that the biomarkers and the conventional criteria are difficult to interpret in our patients, and there these techniques may certainly help. PET-CT allows quantification of the amyloid, very precise quantification. So I propose that in the near future we still use the biomarkers, but if we cannot, or those biomarkers are not conclusive, these techniques will be very helpful. And maybe in the far future we only use imaging techniques to visualize organ involvement. I think they are more precise than the current biomarker-based.
What do you think about the rapidity of the response in the visual response compared to serological?
Well, that's I think a very good remark, so that's indeed something to keep in mind, that the biomarkers may show an earlier response to treatment, to the hematological response than the scan, but we are not sure yet.
Thank you.
I think, for example, and we know from when there's a hematological response, you already quite soon after the hematological response see, for example, improvement in the condition of the patient and also lowering of the NT-proBNP, whereas the amyloid is not yet regressing. So I imagine that with these nuclear techniques you won't see a significant decrease of the amyloid, whereas the patient is improving and the NT-proBNP is already going down, because also the toxicity of the free light chain is not there anymore.
Yeah. In relation to the artificial intelligence, is there a central receptacle for the data upon which the AI would be used? So in other words, is there a worldwide database that the AI can crawl for patterns of information? And if there's not, should there be?
Yes, that's a very good question, because what I showed was an example of machine-based learning, which is a very simplistic way to use artificial intelligence, but deep learning would be more sophisticating, probably more sensitive or more useful. But to do that, you need many data, large databases. So, and I know for ATTR amyloidosis there are some data that we had the TALS register, and there's also another contribute register now going on. And for AL, I'm not sure, but Stefan, maybe the AMN database would be useful for these purposes. Can you comment on that?
I don't think we have databases to reach this goal yet, but maybe this is something the society has to think about to create it. I think that's a very good suggestion. Yeah. Thank you.
Thank you.
Well, there's a question answered for Kastritis. Yeah. Thank you.